Welcome to this short talk on the anatomy of ward interventions into the chest. We're going to go over some procedures and hopefully you'll be more confident when you're coming to put tubes or needles into somebody's chest, something that's always very nerve-wracking when you're doing it for the first time. So we're going to go through the anatomy around a chest drain, pneumocentesis and pleural aspiration. Chest drains may be placed to treat either pneumothorax or less commonly a hemothorax. An adult chest drain has roughly the same external diameter as an adult little finger, about 8 to 13 millimeters, so it's quite a big tube. The ideal position is where the ribs and intercostal spaces can be easily palpated under the skin. We don't really want to be pushing it through a great big piece of muscle or any nerves. Also, we want to put it in a position where we don't think there's likely to be any organs just behind it in case we go too deeply. And also, as the drain will be placed for a long period of time, we don't want to be going through a muscle which is moving around a lot, because that would be too painful for the patient. So if we look at the chest, anteriorly we've got a large muscle, pectoralis major, which we don't want to go through. On the back we've got an even larger muscle, latissimus dorsi, which again we don't want to go through, and also the scapula is pretty tough. On the side of the chest there's an area where we can feel the ribs and the intercostal spaces fairly straightforwardly between pectoralis major and latissimus dorsi. So this is looking like a good place. We want to make sure that it's above the diaphragm, particularly as with a pneumothorax the diaphragm is likely to be raised on that side. So here we have the safe triangle on the side of the chest. The anterior border is in blue, is the lateral border of pectoralis major. The posterior border in yellow is the anterior border of latissimus dorsi. The inferior border is the fifth intercostal space, which is at the apex of the diaphragm in expiration. The top of the triangle, which is cut off, is formed by the base of the axilla. So this is the area where you want to place your chest drain. The areas away from the heart, above the diaphragm, not going through big muscles, is anterior to the long thoracic nerve, and it's below the axilla, so you can't go into any major vessels. So let's look at the bony landmarks of that triangle on this skeleton. We can feel the manubriosternal joint, and just below the manubriosternal joint we know that's going to be the second intercostal space. We can feel below that one again, and that'll be the third intercostal space, and further down still will be the fourth intercostal space. If we come across at that level, we'll be feeling the fourth intercostal space, the space we want to go into, or possibly the one below. Note that it's difficult to feel the fifth intercostal space as the costal cartilages are merging together at the front. The anterior and posterior limits of the triangle will be determined by the big triangular shaped muscles, pectoralis major at the front and latissimus dorsi at the back. So you can work out from feeling these bony landmarks the level at which you want to be placing your chest drain into the chest. So let's look at the anatomy of the intercostal space itself between the ribs. If you remember, the intercostal neurovascular bundle sits just underneath the inferior surface of the rib. In fact, I can feel a small groove there, which it often sits in. So we don't want to go close up to here and injure those vessels. But there's also the collateral branches sit just on the surface of this rib. They're much smaller, but still we don't want to injure them. So really we want to go into this space and place our chest drain in the lower half of this space into the pleural space. You can dissect this under local anaesthetic. Once you've made your defect, check that you are in the right space by placing your finger through the hole and make sure you're through the pleura and feel the lining of the pleura on the inside of the chest. Then you know that you're in the pleural space. Let's just have a brief reminder about the intercostal muscles and arteries and nerves, because we're going to go between these ribs and through these intercostals. Remember the various layers, and on the inside of the innermost intercostal there'll be the parietal pleura. We want to be aiming to go through the muscles just above halfway between the ribs. This way the intercostal vein, artery and nerve are protected behind the inferior border of the upper rib, but we also need to be wary of the smaller collateral branches which are at the superior border of the inferior rib in the space you're going through. When you're putting your local anaesthetic in, you can feel these various layers, and as you go through the innermost intercostal and the pleura, you can sometimes feel the needle pop through. In the case of tension pneumothorax, needle pleurocentesis to decompress the pressure in the pneumothorax is a life-saving procedure which needs to be undertaken immediately. This will prevent the increased buildup of pressure and shifting the mediastinum away from the tension pneumothorax and kinking the great vessels and the patient going to cardiac arrest. Undertake the procedure of the patient lying flat and supine. They're usually fairly ill anyway. We can use a needle because we're only releasing the pressure, therefore we can easily go through muscle with minimal damage. It's not going to be staying in long term, so we can again go through muscle. The position to go through is in the anterior chest wall, in the mid-clavicular line, and the second intercostal space. And this can be the same on both sides. It's far enough lateral from the mediastinum, so you won't be going to the great vessels and causing any damage or bleeding. And if it's in the second intercostal space, it's high enough so that you're not going to go into the heart. Remember the anatomy, and you can do it confidently, save a life there and then. Don't forget to leave the needle in before you send the patient off for a chest x-ray. And if you suspect it, put the needle in before you do the chest x-ray. Our last procedure is pleural aspiration, and this is a drainage of excessive fluid from the pleural space. It is commonly associated with metastatic cancers, primary lung tumours and infections. It's a relatively small caliper needle, and the fluid is at the dependent part of the pleural spaces. The best approach is posteriorly or posterolaterally. Have your patient sitting against a table with slightly bent forwards, so you can see their back comfortably. The seventh intercostal space, just below the tip of the scapula, is a good entry point for your needle. Remember where the intercostal neurovascular bundles are and try and go in the middle of the space. We'll frequently do this with ultrasound scan now, and if you can be confident with the ultrasound exactly where the fluid is, and they're not going to go into the diaphragm and hence into the abdomen, you may be able to go slightly lower. So in summary, remember the anatomy. Avoid the big vessels in the mediastinum, avoid the heart, and stay above the diaphragm. Know where you're aiming for. You can always get a feel of the direction of the tissue while infiltrating your local anaesthetic, as this syringe will have a much smaller needle on it, and you can aspirate to see if you're in the right place. Aspirating air is good if you're draining a pneumothorax or placing a chest drain. Fluid is good if you're doing a pleural aspiration. Fresh blood is not ideal, but altar blood is good if you're draining a pneumothorax. If you get bowel contents, you're way off, and call your medical defence unit. Thank you.